for our clunkiness. We're all learning this as we go.
And I need a moment.
Yep, you'll have a moment here.
Hello and welcome to the Elder Justice Conference. My name is Leanne Colgan with Salt Lake County Aging and Adult Services, the host of this event today. You are joining the Taking Our Shot at Protecting Our Health session, and I will now turn my time over to Audrey to introduce herself.
Okay, and just for those that are doing the technical support, I'm not being able to advance my slides. I don't know if you need to click on something while I'm introducing myself. My name is Dr. Audrey Stevenson. I am the Division Director of Family Health Services of the Salt Lake County Health Department. Throughout the last year, I have been the co-vaccination branch director for the COVID vaccination response. And so a lot of my comments today are going to be talking about equity and how we can ensure that we're protecting all segments of the population. And again, I still can't advance my slides. Let me see if I can do it over here. I apologize, everyone.
Oh, there we go.
Okay.
It looks like we got it. I just
Think
sent
it
Justin over
works.
to
Thank you.
Okay, in the time that we have together this morning, and thank you for attending this session, we're going to talk about the importance of vaccines as we age, because vaccines continue to be the #1 public health achievement of the 20th century. And we've continued to see that we have the ability to protect ourselves and others. I'm sorry, I thought I had, let me just take a minute and close this so that we don't have any more disruptions. And I lost my train of thought, but I think I was talking about the vaccines, the importance of those in protecting our communities from vaccine preventable diseases. And we've seen a number of outbreaks over the past few years, and I want to speak to that a little bit, especially with the lens of equity. We're also going to talk about some of the different vaccine types and choices. We're also going to talk about how we use vaccination data to inform the public and how we make it available for other individuals to be able to access. We're also going to talk about reducing barriers at our vaccination clinics, improved registration progress that we've made throughout this response, and then finally to wrap up with some cultural competency considerations. So with that, let's see if I can find the way to advance my slides again. There we go. So I want to start by talking about a concept of herd immunity. And as you can see in this picture, we have individuals that are depicted as being immune. And there's a couple of things that help to influence immunity. And one of those is that individuals who have had a disease, for certain diseases, we will build up antibodies and it will protect us for a period of time. There are some diseases that once you recover from them, you may have longer periods of immunity than others. So an example of that, seasonal influenza. Even if you get a vaccine or you have the influenza, you may have some immunity for a few months from that particular strain, but that can wane over time. And to the point of aging individuals, as we get older, our immune systems start to wane. And so it's more important for us to focus on individuals that are older adults to ensure that they're being adequately protected against these vaccine preventable diseases. Now, the individuals that are depicted in yellow are those people who are vulnerable. So what you can see is that in situations where we have an individual surrounded by individuals that are immune, then they're incapable of transmitting that disease to others. You can see the individuals that are looking like they have COVIDs, because, you know, we think of the COVID virus, you know, with these spike proteins on the outside of the virus. And so those people in red are depicting the COVID disease in particular. And so what you can see is that in situations where every person around them is immune, they're not capable of transmitting that disease, so it will stop with them. there are some factors that affect herd immunity in addition to the waning immunity that we have, and it's called immunosenescence. And that is individuals as we get older, our immune systems don't work quite as well. But there's some other factors that affect herd immunity as well. And the R with the little zero is pronounced as R naught. R naught is a statistical modeling that helps us in public health and in medicine to be able to determine for a particular disease, how contagious is it going to be for other people. So for example, the R naught for measles is much higher than the R naught for something like a hepatitis A, for example. And so the number of people that are more likely to get a disease from an individual case changes depending on a number of factors. And one of those factors is the mode of transmission. If it's easy to transmit the virus, then it's going to be easier for more people to contract that disease. So for example, when a disease is airborne, and we've known for months now, for the past year, that COVID is one of those diseases that can be airborne. And so it's transmitted by, saliva, it's transmitted, by other particles when people are breathing out or coughing, and it gets aerosolized. Individuals can get that. Measles and varicella or chickenpox are also transmitted airborne as well. Well, not only is it airborne, but we also have other transmissions. So fomites refers to surfaces where, if you touch a doorknob or you pick up a pen or pencil to someone else who's infected and they leave that virus because it was on their hands or it was on some other body surface, then that mode of transmission occurs. So in different diseases, the mode of transmission is going to influence how communicable it's going to be to other people. So how likely people are going to be to catch it. Again, when it's aerosolized, the problem is that air can stay stagnant. So I want you to think of this situation. If you're next to somebody who is a secondhand, you're exposed to secondhand smoke. So a smoker goes by, or somewhere in your proximity, someone is smoking. Even though you can no longer see the smoke in the air, you still can smell it. And so this tells us that there's still particles of that within the air. And this is the same situation that we have with the transmission of diseases, is that it can remain in the air for a period of time. Now, the exact time that it stays for COVID, we think may be an hour before or an hour after an individual is there. So somebody coming in after someone has been seen in a clinic setting, for example, and maybe the person had their mask off because they were examining their throat or they happened to cough or whatever, that can be aerosolized and can be in the air. Also, we need to know about the level of immunity that's happening within that community. So for example, we are currently at about a 30 to 35% level of immunity in Salt Lake County. And some people are estimating that a little bit higher if they factor in the individuals who have already been diagnosed as having had COVID, plus those people who are now vaccinated. For many diseases, this level of immunity differs. And so, for example, for measles, which is very highly contagious, as we mentioned, the level of immunity needed to protect the community is about 95%. We have estimated in the US that the level of immunity that we need for the COVID needs to be around 70% or above. So a minimum of at least 70%, and there are some that are saying 80, 85 would be even better. Fortunately, it's not that 95% because I don't know how we would be able to get that to that level. And then last but not least, there's the concept of efficacy versus effectiveness. And I think you sometimes hear these terms used interchangeably. We often will hear them with regard to vaccines. So you'll hear that, the vaccine efficacy for the seasonal flu vaccine is 54% in the population. Efficacy refers to how well a vaccine or a medication works in a controlled clinical setting. So when you're looking at the efficacy of an antibiotic or a vaccine or some other treatment, efficacy has very controlled circumstances. So we've been watching this very carefully over the past year as we've been watching this development of these COVID vaccines. And we've been hearing reports, 100% efficacy, 95% efficacy. But this was very controlled, selected individuals that participated in many of these studies. Over the last few months, the public and the scientific community has really challenged these vaccine manufacturers and scientists to really be more inclusive in these studies, to make sure that we're using a wide variety of age groups, that we're using a wide variety of ethnicities and genders, because we want to make sure that the efficacy data that is being released or is being determined really does pertain to the entire population. Now, effectiveness, on the other hand, refers to how well it works out in the community without having those controlled circumstances. So we're almost more interested in the effectiveness of a treatment, vaccine, or therapy than we are the efficacy, because that's our real world data, how well it's going to actually work for all of us. There are a number of vaccine recommendations for each age group. And I show this to just show the complexity just of those individuals 18 years of age and older. Now, this is important for you in your work because most adults have not received all of the recommended or required vaccines. Many of us are older, and there have been a number of vaccines that have actually been added since we received our childhood vaccines. We have a lot of adults that we're working with that they figure, I got all my vaccine as a kid. I don't need to get any more vaccines, and I don't like to get a flu vaccine. So we may hear those kinds of conversations. So it's really important when we're starting to see outbreaks of things like hepatitis A, measles. We saw mumps outbreaks in recent years. We've seen meningococcal or meningitis types of outbreaks. So, and we've seen chickenpox even in older adults. So as we start to see these kinds of circumstances, it tells us that either there's waning immunity in our older adults, or that these individuals have not been adequately vaccinated. So, back to my previous message, vaccines are the best way of being able to prevent a particular vaccine preventable disease. Now, no vaccine is going to be 100%. Even what you're hearing about the COVID vaccine, they're telling us they're not 100%. When we hear about efficacy or effectiveness, this is an average. So you may have one individual that has a much lower response than the average. You may have other individuals that have a much higher response. And so what is important is that we still promote those vaccines to everyone, because there's still the chance that the vaccine is not going to be 100% protective. But what I tell people as far as vaccines is that what the vaccine does is it at least gives your immune system a chance to start to work towards a particular disease. So even if you are exposed to that disease and you actually come down with that disease, it's going to be much milder because you have some immunity from having had the vaccine. This is particularly true when we're starting to promote the COVID vaccine, and in a few months we're going to be wanting to promote that flu vaccine again. The flu this last year was much milder because of all of the precautions we were taking against COVID. So that social distancing, that hand washing we were doing, sanitizing surfaces, staying away from people using the social distancing, and finally, face coverings. All of these things were really effective with the COVID, but they were also really effective with preventing disease, the influenza this last season. And so as we're trying to promote these vaccines to our clients, we need to remind them that even though it was a milder year last year, we're worried as we're starting to decrease some of the social distancing, wearing of masks, some of these other precautions, that we're going to see more cases of influenza. In an older individual who gets a flu vaccine, the chances of dying from the flu, even if they contract it, or having to be hospitalized, is much, much lower. than the individual who's unvaccinated. And people who have other chronic diseases are at a higher risk of all of these diseases that are listed on this list because of their other chronic conditions, making them more susceptible. In many cases, certain chronic diseases such as diabetes, for example, can reduce a person's immune system and make them more susceptible to things like influenza, blood infections, and so on. So I think it's really important that we know what vaccines adults are having. We ourselves need to make sure that we're being protected. We need to make sure that we receive all of the vaccines that are available to protect us so that we can continue doing the important work that we're doing and protecting our family members we come in contact with and our clients. So let's talk about what happened with the COVID vaccine response. So as you remember, back in mid-December of 2020, we had the first doses of the COVID vaccine, and it was Pfizer vaccine that was rolled out to healthcare systems. The reason for that is because a lot of the deaths were occurring in the hospitals and were associated with individuals either caring for those hospitalized patients or individuals that were hospitalized themselves. We also saw a very high number of individuals in our long-term care facilities that were being disproportionately impacted by this disease. So the first two priority groups receiving those first initial doses of the vaccine across the entire country, including here in Utah, was for healthcare providers in the hospital setting. So those who were taking care of those sickest patients were the first ones to be offered this vaccine. The second group were those residents and staff of long-term care facilities. Again, a lot of our outbreaks that we were seeing in those earliest months were occurring in those long-term care facilities, and a lot of those deaths were occurring there. So that was the initial prioritization. After that, the next group that, as the vaccine was rolled out, in the state of Utah, our governor, at that time it was Governor Herbert, determined that the few doses that were trickling into our state in those earliest days would go to local public health departments. So there's 13 local public health departments across the state of Utah, and we were getting a proportion of the vaccine based upon our population in Salt Lake County. So the prioritization of the very first doses that we had back in early January, right after the holidays, was first of all, it was our older adults, so those individuals that were in long-term care facilities continuing, also those individuals that were 70 plus years of age. And so those first doses we would allocate for those individuals and prioritize any of our events to be able to reach out to those. I'm going to talk in just a few minutes about one of the really successful models that we were able to incorporate as part of that. The role of public health was that we were trying to determine the best way to get the vaccine out very quickly, because back in the earliest days and until just recently, we were required to use every dose allocated to our state within 7 days of receipt. And so there was a lot of onus for us to be able to have large throughput types of clinics so that we could get people protected very quickly and use our vaccine very quickly. But part of what we needed to do, even starting with the very first doses, was to determine equity. So how do we create a model that ensures that all people have equal access to this vaccine? And that it's not only those people with transportation or those people who have flexible work hours or other circumstances that makes it available for them. And we'll talk more about that as well. In this chart, this was through the first part of May, and you can see that based on age group, those individuals that are older that are depicted by the red line at the top, so this is our 70 to 75-year-olds, did the best in being able to get their doses. Now you can start to see from this chart that when we started to have the doses more readily available, because our first doses, we actually would get a few hundred. And it wasn't until the second week of January that we actually started getting adequate enough doses for us to be able to give, a few thousand per week. At the end, when we were doing our highest number of doses through our events that were just associated with our health department, we were doing over 30,000 doses per week. One of our highest days, we did 8,000 doses in a single day. And we haven't been the only vaccinators over the last several weeks. We've had other vaccinators within the community. So this is depicting statewide the number of individuals by age that have now at least received one dose of the vaccine. So you can see if we're looking at that threshold of 70%, you know, we have a couple of groups, again, our older adults that are reaching that immunity threshold, but we have a long way to go with our younger adults in ensuring that we get the community adequately protected. Here we have the same depiction by ethnicity. And so you can see through May 1st that the group that has received the most vaccines and has the best coverage are Caucasian or white individuals within our community, followed by our Asian Americans that are in our communities. One of the groups that is struggling is our Black or our African American, and you can see that they're only close to a 30%. So our equity work is pretty straightforward, that working with our minority communities is going to be key in ensuring that we get that herd immunity that we need for the entire community, and making sure that everyone has equal access to this vaccine. Here by 100,000 population and by race and ethnicity, you can see again these same groups, and you can see which of the groups are depicted by the gray column above each of those. So again, Native Hawaiian Pacific Islanders, you can see a couple of blips, and they have coincided with some of our larger events that we've done within those communities. And I will say that many of our community events have been much more successful in being able to reach these populations and ethnic groups than having our large throughput types of events. And I will talk more to that in just a few moments. So let's talk about some of the strategies we've used in addressing these disparities. Early last year, we had the opportunity of administering 500,000 doses of flu vaccine in Salt Lake County. Now, unfortunately, we received the vaccine late in the season, so it was actually late October, and many individuals had already had access to the flu vaccine at that point. Well, we contacted Aging Services in Salt Lake County and developed a partnership to be able to practice how would we be able to deliver our COVID vaccine once it was available as a drive-through or a walk-through at a senior center. And this was really an important model for us, because this partnership helped us to be able to identify how are we going to be able to provide services to individuals who maybe lack transportation, or they have a mobility issue, or there's some other factor that would keep them from being able to be vaccinated. We also did work with analysis of zip code and coverage levels. And so we've had our data team from the earliest days last fall identifying where did we have the lower uptake of the flu vaccine. And as we've continued to be able to identify in which zip codes do we have more diverse populations, and what is the coverage for these zip codes based on their ethnicity and their coverage for both the flu as well as the COVID vaccine. And we've continued to monitor that both in terms of ethnicity, where we look at ethnicity as a, we're stratifying by ethnicity, but we're also looking at certain zip codes. So interestingly enough, in the earliest days of the COVID vaccine, the zip codes on the east side of Salt Lake County had higher coverage, even though many of our events were over in the northwest part of Salt Lake County. So our Maverick Center, which has always been one of our larger throughput event sites, is over in the West Valley area, and yet we're seeing coverage levels that are much higher over on the east side. And so this helps us to inform our work of how we do equity work, going into those communities, working with those communities to be able to raise those vaccine levels. Now, one of the other issues that came up as we partnered with Aging Services for the COVID vaccine was homebound. And so this actually wasn't just unique to Aging Services, but throughout Salt Lake County, there was a real challenge once the doses were available for age groups. How do we get into homes if a family is not being served by a home health agency that is able to vaccinate? And so this was another wonderful partnership that we had with Salt Lake County Aging Services, is that they used their nurses, and we added a few nurses with them, but they did all of the registration, and there were a large number of individuals that otherwise would not have access to the COVID vaccine in those earliest days that were served because of Aging Services. So really a lot of accolades to them for their hard work. Continuing on with the partnership with Aging, the way we were able to accomplish the COVID vaccines for our aging group, they being Aging Service, identified those individuals that were actually using other services through Aging Services. They used their Rides for Wellness program to be able to provide transportation to those individuals who had mobility or had transportation issues, bringing them over to the senior center. We used the senior centers, and when we were testing this during the flu season, remember our senior centers were closed at that time. So we were using the drive-through when individuals were picking up their lunches and to provide that flu vaccine. And so they were able to promote this through their newsletter and other activities to help to promote the flu vaccination. But the Ride for Wellness was able to bring those individuals to the senior center for them to be able to receive their vaccine. We also were able to include the vaccination of the caretakers. So the caretaker of that individual who is homebound was also able to be vaccinated at that time. And then Aging Services did a tremendous job in reaching out to individuals, helping them get registered, and then working with us to determine the numbers of individuals and the staffing we would need for that particular event. And I can't thank the staff, Paul and all of his staff that worked so very, very hard for this successful activity. And I really do think it made a big difference within the community. In addition to the activities that we had with Aging Services, we've had a number of clinics at our mega sites. And the mega sites are both at the Mountain America Expo Center as well as the Maverick Center. And I'll show you a picture in just a moment of the drive-through at the Maverick Center. These facilities have done as many as 3,000 doses in a single day on that property. On our longest day, there was a 3-hour wait, and that was early in January when we first opened up the mega site. Our first day there was on Martin Luther King Day. So we were able to open that up to those 70 plus and have people registered and vaccinated at that site. So the mega site has continued to be very, very productive. However, in recent weeks, what we're seeing that there is a dwindling or a decrease in the interest in individuals going through the mega sites. Now, in the earliest days, again, back to the requirement that we get the vaccine to individuals as quickly as possible and to use our vaccine within 7 days, this was the most productive way for us to be able to serve large numbers very quickly. So we had the two models. We had the walk-through at the Mountain America, and we had the drive-through at the Maverick Center. In tandem with that, we've also had some smaller events out in communities. So when I showed you the blip of the increase back in March with the Pacific Islanders, we've had several events with certain ethnic groups working with those community partners to be able to provide sites where we did several hundred, and at 2 of the Pacific Islander events, we did 750 plus at each event. So you can see that when we see those kinds of numbers at a community event, we're going to be starting to make an impact within that community. So the mega sites have been wonderful, but as we're starting to look at a decline and more individuals within the community that have the ability to vaccinate, individuals that may have waited to get a vaccine because they didn't want to deal with the crowds, they didn't want to have to, experience a wait. We were able to get it more efficient in the weeks that since that opening, where we were able to get a wait time down to 30 minutes. So, and that included the wait time after the 15 minutes after receiving the vaccine. So it became a very quick process for people. This is another picture of our drive-through event. Our Maverick, when it's at capacity, we can have 10 lanes going, and we can do over 200 people per hour through our drive-through. We have been operating both of the mega sites now for 6 days a week now for several months. And we're starting to look at, again, declines in the numbers. And so moving forward, we'll have to look at what model works best for the community as individuals have more options for receiving a vaccine. In addition to our 2 mega sites, we also were able to purchase with monies from FEMA 2 mobile vans. And these mobile vans, we use more for smaller events, just because we don't want people to have to walk up and down off of the unit. So we use them more to transport our supplies to an event. However, we could use them. There's the ability to actually lift a wheelchair up onto these units. So these were another model for us to be able to take these vaccines into community settings and be able to have events in the community where people live. In consideration of the delivery of vaccines, we've used a lot of different strategies, and one is the use of community health workers. Our community health workers have been extremely helpful in being able to go into the communities where they live and where they work. And since they're individuals from those same ethnic groups, I think that there's much more trust. The different community members are receiving education from them. In many cases, they're helping them to link them to resources. So for example, an individual a family that's being put into quarantine or isolation in the past few weeks because they had COVID, they were either testing positive or they were ill with it. And they were having to miss work, they may have food insecurity. And so the community health workers were able to go in, provide resources to these families, be that food boxes, be that help with paying for utilities or rent assistance. They were able to identify a lot of the needs for these individuals and be able to meet those needs. In addition, they've helped us to work with these communities because there is some distrust in some of the communities with government in general. And they provide that level of cultural awareness and sensitivity that we need, and are working as liaisons as we work with many of these groups. We've also had an uphill battle in dispelling a lot of the myths. I'm sure that each of you have heard, several of these myths, anything from, we're trying to put chips in people to monitor them to, the vaccine causing sterility. So there's a lot of misinformation that's out there, and it creates a lot of questions in individuals' minds. And being able to use a community member who can help to dispel those myths has been really, really helpful. Also having educational materials, one that they're at a literacy level that people can understand, but also providing those educational materials within a person's native language so that individuals can be informed, they can read about benefits and risks, and they can get other information about the vaccine and about COVID in general. And then we've had to work with our registration system. We've gone through 2 different registration systems. We used our electronic medical record initially in the earliest days of this response, but over time, we found that the registration system was really clunky and difficult for people. The first day that we had our registration system open for people to be able to schedule at our Mountain America site, it crashed. We had 30,000 people within the first hour that were on the system, and it crashed. We were able over the next 3 hours to be able to call all of these people back and be able to get people scheduled. Many people we couldn't schedule for several weeks out just because we had limited doses. So we went to a different registration system that was a little easier, but I know that our registration system was very difficult for many people to navigate. In certain circumstances, an individual doesn't have internet access. And so if they're having to go online to be able to schedule an appointment, that's going to be a barrier for them. If they're trying to talk with someone or they're trying to register and everything is in English and not their native language, that creates another barrier. So we set up a phone system where individuals could call, and we actually had a full bank of individuals, a phone center that was created that we were able to contract with, so that 5 days or 6 days a week we had coverage for people calling in. Either they needed to cancel an appointment, they were having trouble getting an appointment, there was some other issue for them, and we were able to use those interpretive services to be able to help people get registered to receive a vaccine. The vaccine delivery strategies we've used, we've been going through community-based organizations. And so using those community health workers, also having many of these communities coming to us directly. Early in the response, I had the opportunity of meeting with the Mexican consulate and talking to them about what were some strategies in working with individuals from their communities that could be trusted, so that we would be able to ensure that they were being adequately vaccinated. And they were very, very helpful with us. So these community-based organizations have been really, really helpful. And as I've mentioned, many of them are some of these ethnic groups. We've been working with Comunidades Unidas. We've been working with the Pacific Islanders, and many of these organizations we've been able to have partnerships with, and we've been able to provide events in their communities and amongst their members of their communities. Faith-based organizations, we've had a lot of church focused types of events with the Muslim community and with some other faith-based groups. Again, bringing people together where they're comfortable and where they can bring their family members and their neighbors and be able to receive the vaccine. Mentioned the mega sites before, but in addition to the mega sites, we've also had a number of satellite clinics. So we will set up at a site, we'll advertise, let people know we're going to be there, and then be able to provide the service for as long as we need to. Now, in addition to the satellites that we're doing for communities, we also have been providing for some workplace types of vaccine events. So for example, an employer who's either had a large outbreak of COVID cases and would like to protect the rest of their workforce, we've been able to go in and provide vaccines on site for those groups, as well as testing for the COVID virus. But we've also been able to have other satellites. So in addition to those communities, being able to have them at schools. So for the past several weeks, we went to each of the high schools and had satellite clinics at those high schools for those 16 to 18-year-old students, so we could get them vaccinated, or at least give them an opportunity to be vaccinated prior to the end of the school year. And then finally, we've had pop-up types of clinics where we will go to a Rancho Market, or we'll go to the Asian Mall, or we'll go to Magna. We've also gone to Copperton, and we just show up and we try to have it at the end of the day. We try to have it in a community place where people driving by are going to see this, and just providing another opportunity for people to have access. Now, I think one of the real benefits is, as we've seen more vaccine become available, individuals have a number of different options for being able to get those vaccines. With our equity work, we've continued to prioritize those populations. And again, the priority is for us to be able to identify those individuals that have the greatest risk because they haven't had access or there's some other factor that's creating a barrier from them to be vaccinated. So that has been our priority work with our equity, is to be able to identify zip codes, ethnicity, other groups that are disparate from the general population in terms of their access to the vaccine, and trying to provide materials and support to help them to get the vaccines that they need. And all of this is through a lens of cultural sensitivity. We have had trainings for all of our workers at all of our sites in cultural sensitivity and also unconscious bias, so that, you know, individuals are really being aware of how even their mannerisms, their way of speaking, eye contact, all of these affect a person's perception of the care that they're receiving. One of the other issues that we've had to be very cognizant of is that we provide safety at all of our events, and that safety is for the benefit of those coming for the vaccine services, as well as for the protection of our staff as well. Now, certain cultural groups have a distrust of law enforcement, and so in certain circumstances, we've been asked to provide the security in plain clothes in an unmarked vehicle. And, you know, we try everything we can to be as sensitive to the needs of that particular group we're working with as possible. This is a survey that went out to nurses across the country. And this was actually done just a couple of weeks ago. And you can see that when we're looking at, even with healthcare workers who we would think would be greater in the uptake of vaccines than other groups, that we still have some tremendous challenges. And I think that there's a definite crossover into the general population as well, especially when you look to see, yeah, there was about 34% that were going to get the vaccine as soon as it was available. And then, you know, about another 30% who were saying no, and a quarter of the people that were saying that, you know, I'm really not sure. So a few people were planning to get it within the next 6 months, but they wanted to wait. And I remember this myself early last fall when we were starting to hear about some potential dates that the vaccine was going to be released. I remember thinking myself whether or not I wanted to be at the front of the line or whether I wanted to, you know, hold back a little bit and kind of see how people were doing with the vaccine and tolerating it before I was vaccinated. But after a few days of reflection, I actually volunteered to be in one of the vaccine trials that was in Salt Lake County, but I received placebo. So, you know, here I was all ready to get the vaccine and get protected early on, and only to find out that I had received placebo and had to go with everybody else to get vaccinated. So, but when we look at reasons why people did not want to get vaccinated, they're fearful of the side effects of the vaccine. They feel like, you know, the studies haven't told us what the long-term effects are going to be. Now, I will tell you that the studies that started last year will go on for 24 months. So all of the studies that were done even early on are going to be going to last for a 2-year period of time in order to ensure that individuals, that we know everything that could possibly happen with this vaccine. Also, that the development of the vaccine was too quick, that they hadn't received enough information about the side effects of the administration, mistrust about the vaccine development, and so on. So a lot of the same types of questions and concerns that we see in the general population. So moving forward, we need to do all that we can to reach that herd immunity, be that encouraging people who still have been kind of holding back on being vaccinated, why it's important that they get vaccinated. The quicker that we can get to that herd immunity, and let's hope that we don't get herd immunity from people having had the disease. I hate to see even another person get the COVID disease, because there's a lot of people who have died from it and a lot of people who have had long-term complications as a result of it. And then, being able to make sense of the information, what we're hearing about the vaccines, helping people to understand, the benefits versus the risks of the vaccines in a very transparent and sensitive way. And then also continuing to ensure that our equity informs our work moving forward. So as we have more vaccinators that are available within Salt Lake County, be those pharmacies, other clinics, other healthcare providers, other vaccination teams like NAMI and community nursing services. There's a lot of different access points, but let's make sure that we're not leaving anyone out in that equation. Let's make sure that we're doing the work to ensure that every person in Salt Lake County has had access to that vaccine and understands why it's important for them. So with that, I will go to questions.
Thank you, Audrey. So if anybody has any questions, please enter them into the Q&A, and Audrey would be happy to answer those. I thought it was interesting, Audrey, about how people are understanding the vaccine and resisting wanting to get the vaccine. I wondered if you could expand upon how you are getting the word out to people so that they're not afraid.
So there's been a lot of information both nationwide and locally. In Salt Lake County, we contracted with a communications group called Love Communications. And in the earliest days, they developed the This Is Our Shot campaign. And many of you may have seen the PSAs or may have seen other, posters or other things about This Is Our Shot. And with the understanding that if we get the vaccine, our return to normal comes more quickly. So this is our opportunity to get back to the things that are important to us, back to work, get the economy going again, be able to lift restrictions. So that was one way that we were getting information out. We also provide information through our community health workers. We've also been providing a number of media types of interviews. Most weeks I get up to 3 requests to talk about the vaccines, talk about strategies, dispelling myths, just really trying to get the communications out there. There are other individuals within the community who have also done similar types of things. Intermountain Healthcare has been providing some education. I've been getting some information from University of Utah, where I graduated years ago. And so they're sending me information, plus I was on faculty there. So that may be why I get it as well. So I think that there's information is coming from a lot of different sources, but I think what we have to identify is, how do people want to hear the information? Do they want to hear it from a community health worker? Do they want to hear it from one of their, their pastor or from one of their church members? Do they want to hear it from, a neighbor? Do they want to hear it from their healthcare professionals? So I think ensuring that the information is transparent, that we're not sugarcoating, that we're not, saying that this is the panacea, that the vaccine is completely perfect, because it's not. We've, heard in recent weeks about some concerns with the Janssen vaccine, but the number of individuals impacted by that are extremely low. So the risk is still, the benefit still far outweighs the risk. But I think it's being willing to answer those difficult questions. So as we have clients who have questions about safety, about, a myth that they've heard, those kinds of things, I think each of us have a role in being able to help to foster understanding.
Okay, thank you. We have about 2 minutes left. If anybody has a quick question for Audrey, if you want to type that into the Q&A, she would be happy to answer that.
Audrey, thank you so much for presenting on this. Sherry, are there any more questions?
No, that was the only one.
Okay, great. Well, so we've reached the end of our session. The session was called Taking Our Shot. I just want to say again, thank you, Audrey. That information was so helpful, and you guys have been working so hard. And as a staff person with Salt Lake County Aging and Adult Services, I just want to say it's been a pleasure working with the health department. So,
Oh, likewise. I think these partnerships are going to be what's effective in getting us where we need to be. So it's been my pleasure to be here today, and Aging Service knows how to get a hold of me if any of you think of questions afterwards or something that I can provide for you. So thank you for the opportunity to be with you today. And enjoy
You're
the rest of your
welcome.
conference.
yes, thank you, everyone. We'll see you in the next session.
Bye-bye.
Bye.